So good morning, everyone. Welcome to this meeting of the Health and Wellbeing Board. I'm Councillor Graham Bridgman and I'm Chairman of the Board. For the benefit of those members of the public who are watching this live or watching it back later, this meeting is being held in a hybrid format. So we have a quorum of members of the Health and Wellbeing Board in the Council chamber, and I am joined in the chamber by Councillors Lynn Doherty, Owen Jeffrey and Joe Stewart. And I've also got Gary Paulson and Katie Summers with us in the chamber. Other board members and substitutes are joining remotely, and they are Councillors Rick Jones and Steve Masters, Superintendent Zahid Aziz, Raghav Bazin from Royal Berks, and I'll come back to Raghav in a moment, Matt Hemsby, Jessica Jundu-Evans, Sean Murphy, Matt Pearce, Andrew Sharp, and Reva Stewart. I will speak a little about Raghav when we come to new members. I'd also like to welcome Martin Earwicker. He is the chairman of the Berkshire West NHS Foundation Trust, and he asked to sit in as an observer. I'm going to treat Martin as a board member for the purpose of questions. So for everything other than the indicative vote, Martin, please feel free to join in. In addition, Richard Wood, who is the CEO of the Berks, Bucks and Oxon Local Medical Committee, is here for item 11. And Shushma Aquila from the Berkshire West Hub is here for item 9. So I will be moving both of those items up the agenda at the appropriate point in order to release those two individuals. Dom Hardy from Royal Berks Foundation Trust will be joining us around about 10:45 for item 12. So depending on where we are on the agenda at that point and where he joins us, I may play with the agenda again there. As you probably can tell, the majority of officers and partners presenting items today, and indeed member of the public asking questions, are all doing so remotely. As I said, we are live streaming, and that's via YouTube, so that members of the public can follow us. To complete the formalities, Gordon Oliver is the clerk to the meeting, and Christine Elsasser is the Zoom host. Now, so far as voting is concerned, we will be taking indicative votes as necessary. So to remind everyone, that is a vote using your Zoom hand, or if you haven't got Zoom up, your physical hand, for everybody who is a member of the board. And then we will move to a formal vote just of those members of the board who are in the council chamber, and that will be a vote using physical hands in front of the camera so everyone can see what we're doing. And I just repeat, Martin, you're not included in the voting process. And finally, just to make life interesting, being a Thursday, there will be fire and lockdown alarms sounding around 10 o'clock. So depending on where we are on the agenda and who's speaking, if it's someone in the chamber, we'll have to shut up for a little while. Thank you, Gary, for muting yourself. So item 1 on the agenda is apologies for absence. So I start and ask whether we've had any apologies.
Yes, Chairman, we have apologies from Dr. Abid Irfan, Paul Illman and Gail Muirhead, Meriden Peachy, Andy Sharp and Councillor Martha Vickers. And we have got a substitute, which is Councillor Owen Jeffreys for Councillor Vickers.
Thank you, Gordon. Now, before I go to item 2 and the minutes, let me start by reflecting that Meriden Peachy has given her apologies, but I believe she's leaving post at the end of November before our next meeting in December. So this would be her last meeting. And I want to thank Meriden through the clerk for the sterling efforts she's made on behalf of Health and Wellbeing and the sterling efforts she's made on behalf of public health in West Berkshire. Just bear with me one moment. And so thank you to Meriden, I'm sure, on behalf of all of us. And the other thanks are to Kamal Bahia. Kamal isn't a formal member of the board, but she is the chairman of the Health and Wellbeing Engagement Group and sits on the steering group. And to say that the amount of work she's put in as chair of the engagement group has been magnificent is under promoting it. Thank you to Kamal for her many years of hard work and contribution to the work of this board. She took a lead role in organising the conference each year, and I thanked her at a meeting of the engagement group on Tuesday, but I did say that I would be doing it publicly. So hopefully that feeds back to her and she knows that we appreciate the amount of effort. So we move on to the minutes. I'm not going to take an indicative vote on this. I'm simply going to ask people if they have any reflections, amendments, anything they want to propose in relation to the minutes, and then I'll go to a vote in the room. So those who were at the meeting, is there anything you want to amend? I can see no Zoom hands. I see no one winking at me in the room. So I will move to a vote. I will propose the minutes from the chair. They're seconded by Councillor Doherty. Thank you. Those in the room in favour, please show physical hand. Who were here, obviously. That is unanimous of those who were at the meeting. So the minutes are agreed. Thank you. I will sign them after the meeting. Okay, we now move on to actions arising, and you have a table of them in your pack. I'm going to work, Councillor Jeffrey. Of course. I'm going to go through the actions one at a time. When we get to that point, and if you remember to switch your microphone on when we get to that point, the right-hand button. Okay, so I'm going to take us through them. And as I say, please indicate Zoom hand and I'll take Councillor Jeffrey's physical hand. 151, we are still seeking an alternative employer representative, and you can see where we got to there. Now, I think before we come to Councillor Jeffrey that we had some movement. I'm reminded we were going to the LEP, and I'll ask Gordon to explain where we are at the moment.
Yes, thank you, Chairman. We did approach the LEP, but given the uncertainty about their future at the moment, they've just decided that it'd be better if they didn't actually join at this time.
So, Councillor Jeffrey.
See if I can make all the technology work. I was just wondering whether we'd actually approached perhaps British Gas, SSE. They're big employers in the area. They both have fairly major establishments in the area. And I mean, obviously, it's very disappointing that Extract didn't feel able to come on board at this time. But I would have thought that either of those would be well worth approaching.
Indeed, and indeed at the last meeting I recall that we also considered AWE, or certainly at the steering group we might have considered AWE as a major employer in the area. So I think anyone who has any tentacles into any of the major employers, given that the LEP has declined the invitation, please feel free to have a chat with them and make Gordon aware, and we'll see where that one takes us. But we are without an employer's representative, and it would be useful to have someone from the employment field in the room. 153, that's being progressed in 2022. 160, phase one, I understand phase one of the COVID recovery dashboard is complete, and phase two is going to be developed using local data. I've got two 160s, so I'll read the second one as well. COVID recovery dashboard. No, that I think that's an old hand, as it were, Gordon. The second item, that's a throwback, so I'll ignore that. 164, we've got the review of continuing healthcare to come back in December. 165, we've got the transition between mental health services for CYP and adults will be addressed in the delivery plan and will be coming onto the strategy shortly. 168, that hasn't happened yet, I think, due to leave and some illness, so watch this space. 169, that has, as I said, thank you to Kamal, who is now leaving us, and that's been overtaken by events, and we will be coming to that when we get to it in the agenda. And finally, on 171, Ian Woolf has agreed to give us a presentation on work of Skills and Enterprise Partnership, and that's going to take place in the December meeting. So that is everything I've got to say on the list of actions arising. Unless anyone has anything to add, I'll move on. Okay, so item 4, declarations of interest. I now look to anyone, apart from the 2 standing declarations that are in your agenda. I look to anyone who wishes to raise a declaration. I see none. Move on again. So we now get to public questions, and we've had 4 questions. They've all been submitted by Paula Saunderson, and welcome again, Paula. Nice to see you. So what we're going to do is the usual format: display the item on the screen, ask the relevant board member, which I think in this case is Councillor Stewart in every case. So Councillor Stewart, to answer the question. And as you know, Paula, you then have the opportunity of a supplementary, which must be in relation to the question and answer given. So that's good. So Councillor Stewart.
Thank you. And
sorry, and I'll leave you to work your way through them rather than me interrupting you at each stage.
Absolutely. Okay. At the moment, my display is not showing me Paula, so I would like to be able to see. I'm just going to scroll. Trying to work through these gadgets can be a little bit of a, especially on a little screen. There we go. Hello, Paula. Lovely to see you.
Hello, Jo.
Okay. Right. Let's just. Apologies, bear with me again, just trying to get my notes, which would really help. There we go. Paula, I have a huge amount of graphs and tables that I would be very willing to send you for this in answer to this question, but I didn't want to just leave you with nothing today. So if you will bear with me, I will go through some of the numbers that I have, and then I'm very happy to send you a pack that includes some graphs and tables that will perhaps wider inform you of the answer to this question. So this is a broad summary and hopefully gives you some of the detail that you need. So you're absolutely correct. The number of long-term service clients has increased. Snapshot data from the last day of the reporting year is as follows. So for 2018-19, we had 1,682 clients. For 2019-20, we had 1,692 clients. And then for the 2020-21 period, we had 1,715. In terms of age bands, across this period, we've seen a reduction in the number of long-term service clients over the age of 65, which is quite interesting, and a growth in the number of those aged 18 to 64. So between 2018-19 and 2020-21, the over 65s actually reduced from 1,012 to 986. And for the same period, the 18 to 64-year-olds increased from 670 to 729. In terms of the type of support that people are receiving, the changes are essentially that there was a significant drop in the number of people over 65 in nursing homes during the period of 2020 to 21, but the number has actually now returned to a similar position to before the pandemic. And the number of over 65s in residential homes also dropped in 2020-21, but has not yet fully returned to the pre-pandemic levels. There has been an increase in number of people receiving support in the community across both age groups. So that's my summary answer for you at this point. As I say, we'd be very happy to send you the graphs and tables that give you more detail should you require it. Do you have a supplementary?
Yes, Jo, thank you very much. That's great. Would it be possible to turn that indicator 35 into a clustered stacked column chart so that you could have 3 sources of information in one picture? So if you stacked the chart with colours, you could have domiciliary, residential and nursing on the stack. And then if you split the column into 2, you could have the 2 age groups, and it would all be on one chart.
I will certainly check and see. As you're probably very well aware, our systems and our reporting is very much geared to the statutory reporting that we need to do. But if we can do anything with the output that we get from that system, absolutely, I will check with officers and see if we can do that for you.
Great, thank you very much.
Okay, lovely. On to question B. So thank you for your question. It is important to note that our reporting system that I've just mentioned is organised in order to meet the requirements set out by government in terms of our statutory reporting responsibilities. Consequently, we can provide the long-term service client data by primary support reason. Examples of this would be memory and cognition, learning disability, mental health, those types of situations or reasons for needing the service. It's also important to note that in adult social care, we make great efforts to see people in the round. So rather than as defined by a specific medical condition, we also try to adopt a strengths-based approach where we try to make sure that we are looking at the strengths of each of those individuals or as part of a family, community or other social group. And consequently, while details of ailments may be recorded within the assessment documents, it will be alongside other equally important data. And we don't therefore single it out currently for reporting or other tasks. The only exception for that is autism, because there is actually a mandatory requirement to record this diagnosis where it's known. And we don't record long COVID separately as a requirement for needing adult social care services. Do you have a supplementary?
No, I find that quite interesting, but no, I don't have a supplementary. Thank you.
Thank you. On to question C. The lower than expected occupancy in the council managed care homes is due to the fact that the homes have not been in a position to admit new residents, and it has not been due to a lack of demand or referrals. The care homes are careful to ensure that they can meet the needs of new residents, and this is affected by a range of factors, including the staffing position and the needs of existing residents. It's noticeable that many people are delaying admission to care homes until the individual's needs are at a high level, and this is affecting the ability of the homes to accommodate new people. We do occasionally admit self-funded clients, but the same considerations will apply. And what I'd like to say is, if you have any specific questions regarding this, I would recommend getting in touch, emailing the details through to me, and I'll make sure that the appropriate team respond to you. Do you have a supplementary?
No, that's fine. Thank you very much.
And then finally, question D. So this particular question doesn't sit nicely within my portfolio, but we've been in touch with the housing team, and the portfolio holder is responsible for the housing team. And they have confirmed that they will review this proposal over the next few months to see how this can be addressed and the advice that they can provide. And again, if I would suggest, if you have any further questions on this subject with details that you would like to send through sort of privately, then I'll make sure that the housing team receive them and respond to you. Do you have a supplementary?
No, that's fine. It wasn't actually covered in the housing strategy. And I think it's important for self-funding families to have more options than they have at the moment. So I'll take that one up further. Thank you.
Okay, thank you.
Thank you very much, everyone. Bye.
Thank you.
Thank you both. And yeah, thank you, Paula. So members, I'm now going to start my moving stuff out of order process to ensure that people get away when they need to. So I'm going to bring item 11, which is the availability of GP appointments, up the agenda. This arose because of discussion, particularly that the leader and I had, about what we were hearing in the community. And I think there was some frustration expressed by the community, whether that's justified or not. And certainly I recall that Healthwatch have also got an interest in GP appointments. And we had a discussion about that in the steering group. So I'm going to invite Katie Summers, who's in the chamber with us, and Dr. Richard Wood. Welcome, Richard, who is CEO of Berks, Bucks and Oxon Local Medical Committees, and was the author of a general letter, I think, to politicians to set out the views of his view and his committee's view on this issue, to address us on the question of I think it's both actuality and particularly perception. So I don't know how you're going to split it up between you, but I leave you to decide.
Thanks, Graham. It's Richard Wood here, BBO, CEO of the BBO LMC. We're the statutory recognised representative body of general practice. I'm the CEO, so I head up the Secretariat, which is there to execute the will of the committees across BBO. Mr. Summers, I wonder are you happy for me to start, and then would you like to come in afterwards, Katie? Is that all right?
I was going to suggest that because I was very worried that you might need to get back to practice. So if you want
I've actually just bought myself a little bit more time, but so we should be all right. I thought what it might be helpful to do, if the committee is happy, is for me to give some local data, some local statistics for Berkshire. It's not specific to Berkshire West; it's the whole of Berkshire, but I think it still gives a helpful picture for you, which will capture some sort of demand and capacity issues which are not reflected in the national data. And then perhaps list some key points which will perhaps aid your understanding and the public's understanding about the issues around access, and especially around remote consultations, which is very topical at the moment. So in terms of statistics, it's no surprise to anyone here that, of course, GP numbers are falling. Certainly, if you look at national data since March 2016, we've lost 1 in 5 of our permanent GPs, as both salaried and partners. So 1 in 15 of our permanent and salaried partners. In Berkshire, at local level, you can actually look at what's called patient list sizes, which is the number of patients who are under the name of a full-time GP. And actually, since 2014, across the whole of Berkshire, there's been an 186% increase in GP list sizes, which speaks volumes for the number of GPs that are out there looking after their patients. Interestingly, there's been 150% increase over the threshold at which nationally published data indicates that there's a decline in patient health outcomes, such as measures of chronic disease, for example. So we really are short on GPs. Everyone knows that, of course. And of course, at the same time, demand is rising. So if we go to BMA guidance, the British Medical Association suggests that safe levels of consultations for GPs is to have 25 consultations in a day if the matters are simple, and 15 consultations in a day if those presentations are very complex. And I can show you there's a lot of complexity out there at the moment. Actually, across the whole of Berkshire, GPs are averaging 32 patients a day. I've had constituents call me in tears, not from this region, be pleased to know, because on a day they've had to deal with 76 patient contacts in a day, which is unsustainable and quite frankly not safe. Here's an important fact for you. Clinical encounters, the telephone or the face-to-face or the home visit, for example, only makes up 20% of the medical record entries in the patient notes. The other 80% is workflow around patient care to support it. That would be reading reading hospital letters, reading patient letters, and processing lab reports, for example, maybe documenting discussions with colleagues, that what we call workflow around patient care. That's 80% of the medical record entries. Now, NHS England data on activity only captures booked appointments, which is, I suppose, is a surrogate to clinical contacts. It does not count the other 80% of the medical record entries which we're doing. If we look at our local data, which we've been collecting on medical record entries and counting medical rate entries since November 2020, between November 2020 and August of this year, there's been a 23% increase in activity. We certainly know from national data on booked appointments that November 2020 was busier than November 2019. But to have a 23% increase in activity since this November gone is very large. And interestingly, that increase in activity is not so much the clinical contacts of a patient, it is the workflow around patient care. Now, I've been thinking for a long time about why that might be the case. I have two suggestions without an evidence base to support it. It's really anecdote. The first one is there's a huge amount of transfer of work from hospitals to onward referrals to do tests for them, and really often in breach of hospital contracts over the interface. We're picking up more work from hospitals. We're also holding more patients who would normally have been seen, but the waiting lists are very long. It's just the way it is. The second thing is there are only so many clinical contacts you can actually have in a day safely. And I think general practice is at capacity. It can't go beyond that 32 contacts per GP per day. And then all the extra demand seeps in from the seams elsewhere, letters from patients, for example, and appears as administration rather than the clinical contact. So what do we do with all of this? And this is really where I start to talk through some issues about access, and especially remote consultations, which is very topical at the moment. The first thing I want to point out is that this is not the demand outstripping supply is not just a problem with general practice. This is a problem which is being faced across the whole system. So it accounts to A&E as well. It includes outpatients departments. I'm sure it includes social care as well. We're not totally sure why this is, but it's massive everywhere. The second thing I want to point out is that remote consulting is universal across the healthcare system. That is, it is the norm in a vast majority of hospital clinic appointments, and it would be inappropriate to single out general practice as just the only profession which is doing this. It's been the norm for ages. I think it's also worth pointing out, because some people don't understand this, general practice operates under an independent contractor model, and partners have unlimited liability for the survival and the sustainability of their business. So if their business goes down, it's not just the business which collapses, it's their mortgage, school fees, the whole livelihood, unlimited liability. It necessarily follows in the GMS contract we have with the NHS, but actually we choose how we deliver our services. So there's a lot of speak sometimes in the public domain about GPs aren't doing what they've been told to do. Well, actually, we're doing what our contract allowed us to do, which is to be able to choose how we deliver our service in order that we can align it best for our own patient populations and the sustainability of our business. Now, getting more down to the nitty-gritty, and I'm halfway through this list now, clinical triage is absolutely critical when demand outstrips supply. You have to be able to identify those who are most in need or most vulnerable and give them the access they need. Telephone call lists, as opposed to pre-booked face-to-face appointments, is absolutely invaluable for clinical triage. If I start my session in the morning and I have a list of telephone calls and the patient has told the receptionist taking the phone what the problem is about, which is really important, I can identify those who are going to need to be called first, probably seen face to face, and address them first. And I have the flexibility in my day to be able to do that. And there's no one waiting grumpily for me in the waiting room. They can continue their day waiting for the call. So telephone lists allow clinical triage, which improves safety. So a message which says we must return to complete face-to-faces or almost all face-to-faces has the real risk of undermining safe triage. But practices are doing a lot of bottom slicing. This is another way we can manage this demand-supply imbalance. That is, if something doesn't need to be seen by a GP, it really should not be seen by a GP. If an allied health professional like a paramedic or a minor illness practitioner can do it, they should do it, or the pharmacist, for example. That's really, really important. We should all be operating at the top of our contract. We now have online access through what we call e-consult, so patients can submit queries through electronic means, where previously they may have booked an appointment. That's very important as part of the triage and bottom slicing. I have had some average practices who will get 700 letters or electronic submissions arriving on their doorstep on a Monday morning. That's the vast amount for a clinician to get through. Coming to the end now, telephone consulting is it's very efficient. So we've done good local audits to show that the average telephone call takes 8 minutes. The average face-to-face for the same problem takes 14 minutes. So you can get through an awful lot more in a phone call, and you can free up a lot more of your day for that other 80% of the work we do, the workflow around the patient. I want to reassure a lot of people out there who may not know this, but actually in excess of 90% of all diagnoses are actually made on the history alone. It's what the patient describes to you, it's their story, it's their narrative. It's very unusual that an examination for face-to-face examination changes either your formulation or the management plan. I far more often examine really because sometimes the doctor's touch is part of the therapy. Remote consultation was heavily pushed in our contracts pre-pandemic. It was written into our contract to achieve a certain number, a minimum of 20%, with the agenda that it will be pushed up year on year on year. And you'll probably remember discussions about GP in hand and Babylon and all these media discussions promoted by the health secretaries at the time, but actually remote consultations and video consultation in particular were the way forward. And in fact, general practice changed overnight. If there have been particular practice issues, but individual practices which have notably difficult access, it's normally because there is something else going on in that practice. There is a challenge going on underneath, which needs support from the LMC, and it needs support from commissioners. They should not be punch bags because somehow they're doing their access wrong, but they're in there to support the patients. And finally, the way NHS England has captured telephone consultation versus face-to-face consultation data, that data capture has changed in the summer of 2020, and we're now capturing much more telephone calls in that data than we were pre-summer 2020. So comparing pre-pandemic baselines of face-to-face and telephone ratios to post-pandemic baselines, you can't do it. You're comparing apples and oranges. In terms of solutions for all of this, I really want to put out there, but actually the GPs are getting a lot of abuse, especially from the media and from the public. It's actually from a minority of patients, but it's very damaging, and especially those patient support workers on the phone at reception at the very front line. We lose them if they are getting abuse several times a day, and we need them. That must be challenged at every level. We should be supporting our practices to make their own local decisions as per their contractual right about how they manage access, because they know their patients best and they liaise with their patient support groups. We need education on the public about hybrid models and new ways of working. And by the way, a lot of the public like the telephone access system. They can get on with their day. It's better for the businesses they work in. It's reducing transport and driving costs. A lot of people like it. That not should be forgotten. We do ask our hospital colleagues, and RBH isn't too bad, by the way, but we do ask our hospital colleagues across the whole of Bob, we need to stick to interface protocols, interface agreements, contractual agreements about who does what, so our workload is not overwhelmed by doing hospitals work as well. and the long-term solution is really to reallocate resource into what we call core GP work. That is seeing people who are unwell or believe themselves to be unwell. We've got a lot of new roles coming to general practice, for example, but they're often attached to bells and whistles to deliver wonderful things with noble aims. But it takes them away from that core work of seeing people on the front line. And that's what we really need to put our resources in. I'll leave it there and I'm happy to answer questions. Thank you for listening.
Thank you very much for that. I think what I'll do, Katie, is take questions on that presentation and then we'll come to you. So members, do you have questions? Let me just see, I'll take a few and then I'll come to you, Councillor Jeffrey. So I'll start with Councillor Jones.
Thank you, Chair. And thank you, Richard, for your very informative presentation. I so understand and sympathise with the problem. Two questions, really. One is, what is the profession doing about recruiting in terms of trying to increase the number of GPs again? And secondly, what do you see as the role of the social prescribers in general practice in terms of helping to manage demand?
Councillor Jones, thank you. Those are really good questions. GP recruitment has been a local and a national agenda for years through various means. GP retainer schemes, for example, trying to capture those who recently left or have other life commitments which make it difficult to work. Unfortunately, they're desperately underfunded. There is not enough money for those. Retention and recruitment in the medical school and more exposure of general practice in medical school is really important. There should be more of it actually in training of all junior doctors. There's lots of different schemes out there. The fact is actually the work demand is so difficult at the moment and the value of the contract and partnership drawings has been squeezed so much over the last 10 years that it's no longer an attractive proposition for many. I mean, I certainly worked between 12 and 14 hours a day. I'm paid for 8 of those. It's really hard. I did an audit of a very busy city practice a number of years ago, and it was showing that for each 4 hours of contracted time a salaried GP was working, they were actually logged into the medical notes for 6 hours and 40 minutes. So that's a 66% overtime, which is just absorbed by your own private time. So we're facing challenges of attractiveness, and the abuse which is going on in the media will make that much worse. It's, waffling a bit. Sorry, I'll go on to the next one. The social prescribers. I have to say, from personal experience, when they were first introduced, I recognised that a lot of my work was actually social problems, which I didn't know I couldn't deal with as a doctor, and I had nowhere to put it. But I wasn't quite sure how it was going to work with the social prescribers. I have personally found that's really helpful. It's helpful particularly for those situations where I can't do anything anyway, but I've got someone else to support them. It doesn't help so much with all the other medical demand I have going my sleeve. I'm not dismissing social prescribers. They've got a place to do, but it's really for the stuff I couldn't really manage anyway.
Thank you.
And Councillor Doherty.
Thank you, Richard. Thank you for a really interesting presentation. And actually, Richard, when you take everybody through the challenges you're facing, you can understand exactly the position you are in. And I'm sorry to hear about the abuse that GPs are facing. I think that's a terrible situation to be in. One of the things that when I'm knocking on doors and talking to residents, they tell me about is around access, because they're only hearing the media. And I just wonder what GPs and practices are doing. And I appreciate probably not GPs because of everything you've just gone through around their communications. And I've raised this with my own GP because, it's the communication. If residents understand what you've very, very simply explained to us, the pressures that you're under, the timescales, the efficiency of triage, then that becomes a far easier conversation to have. But I don't think that patients themselves, from residents themselves, are hearing that level of communication. So I just wanted to put that to you. And then the other thing I was just going to ask sneakily, I know you're covering Berkshire, but have you got any of those figures relating to West Berkshire? Are we a particular outlier or anything that would cause us concern? Or are we in line with everybody? You may not be able to answer that, but I just thought I would throw that one in. Thank you, Richard.
Thank you, Councillor Doherty. So with regards to the data question, I've got data broken down for Berkshire West specifically, but it's only for a population footprint of about 76,000. I don't think there are quite enough practices contributing to that that search data to make it meaningful, which is why I presented across Berkshire. Actually, I've got data for the whole of BBO. Berkshire, Buckinghamshire, and Oxfordshire, and that's a population footprint of about 500,000 of practices submitting to me. The problem is the data submissions are optional for the practices, and they're very busy. It takes a little bit of time, and I probably don't have enough yet. I certainly can't. I don't want to expose individual practices as well, but expose them to performance management, for example. With regards to communications access, the communications issues, you're absolutely right. And part of what I've been doing with the letters through MPs was to promote that discussion and to promote that learning and understanding. When you talk about communication about access policies, there are as many access policies as there are GP practices, because every GP practice does it differently, and it has a contractual right to do so. So those who actually need to promote this, a communication about how to access them, is really that needs to be done by those least able to do it, with the least time to do it, and that's an issue. But I'm talking with various stakeholders at the moment about actually how we support practice in educating about their access policies. As for the wider education of the public, there are media campaigns in BMA. There are posters with practices are putting up on their walls. I'm doing my best. It is actually a massive job, and even if you put something out, it might not necessarily be picked up by the media, for example. But there are national and local campaigns, but it's work in progress.
Thank you both, and Sean.
Thank you, Chairman. Yeah, I thought that was a really interesting insight into some of the challenges faced by the by GPs. I think just picking up on the points about communication that was just raised by Councillor Doherty, I think part of the issue here is that obviously you talked about a direction of challenge before the pandemic, and this is kind of where we were heading, and for very good reasons by the sounds of it. I think the problem is that people see this because it was coincidental to the pandemic. A lot of these changes is that what they're seeing basically is a sector that's not getting back to normal in their eyes at a time when other areas are returning to some degree of normality. I think it's really important that people understand that this is the normal, this is the new way of working, the reasons why it is the new way of working, the efficiencies, the benefits of it, and the challenges that are faced by the sector. And I'm not quite sure that's out there yet in terms of public understanding. And I think that would help a lot. And you've just talked a little bit about how you're looking to do that. But my perception is I think partly that's where the public are, is they're expecting some sort of return to something that we're not going to return to, if that makes sense.
Thank you, Mr. Murphy. Those are wise words, and actually you've really captured what I was trying to say. You notice I didn't talk much about COVID in this. I think people are fed up with hearing it. They think it's an excuse. Actually, the risk of contamination is still extremely high, and standard operating procedures still mean we have to protect. But actually, it is more than that. Although that is important, it is about how we manage a huge amount of demand, unlimited demand actually, with very, very limited supply. And I'm afraid to, I won't put a valence on it. The hybrid approach is the new normal, and we as a society need to understand that. At the moment, the population is going through a grieving process, grieving for what they've lost and what they've gone through, and it is normal to blame. It is normal to lash out. And it's also quite normal for that to be to those closest to you and those who you value most. because we are that open avenue and we're accessible comparatively the rest of the healthcare system. We really are, and I think this is a natural phase of population recovery. And I very much hope, and I'm sure we will get through the other end and people will understand a new way of working. But what I want to do is limit the damage which is happening to the profession, and especially our reception staff and our administration team in the process, because it's pretty catastrophic.
Thank you.
Indeed, and I think hybrid and virtual are the new normal in all sorts of areas. Councillor Stewart, and then I'll count to Councillor Jeffrey, and then I'll come to you, Andrew, because I think you probably can wrap up as well as any of us.
Thank you. Thank you, Richard, for such an interesting, I've scribbled so many notes down because you had so many interesting facts. I don't want to prolong the conversation about communication, but I think it would be, so my question to you, I guess, is, I'm a big advocate of the hybrid model. I have used it with my own GP surgery, probably even before the pandemic. They had started to work in that way, and it really worked for me, as you said, where I was able to still be working and to wait for the GP's call. And sometimes I didn't need to go in, or if I did, I could go and see another practitioner, which was absolutely perfect for me. You have organisations represented on this board here, and I can see that the GP surgeries themselves are trying to promote the hybrid model and communicate that within the surgeries. Is there anything that this board can do, and this potentially might also be a question to the rest of the board members as well as to the chairman, that we can do to help with that media issue, which is clearly, I don't want to talk too much about the media. It's been, it can work both ways, in bad and good ways, and we won't talk about fuel at the moment. But is there anything that this board can do to support you in that endeavour?
Thank you, Councillor Stewart. I really appreciate that. Well, I've got, oh, that's gone echo. Sorry, I had echo there. I really appreciate that. Actually, that's part of the reason why I'm here. And I'm going to respond to your suggestion that if I could open that up to the rest of the team here, because this is actually, this communications campaign is actually quite new to me. I've been in the job for 3 years. I'm also in the background trying to build an ICS, so it all contributing to that. So there's a lot going on at the moment, and I'm grateful for people's views on how they might be able to help.
Well, I'm sure we will come to that when we get into the general debate, and I sympathise. Yeah, I'm sort of on the periphery of the ICS, and I can imagine it's interesting. Yeah. Councillor Jeffrey.
Thanks, Chairman. Well, my question was really going to be Councillor Stewart's. So as not to repeat the question, how do we go about informing the public? One thing that I'm aware of that perhaps I could try and sell back to other members of the health service is that my elder daughter's GP surgery, since the start of COVID, has been putting out a WhatsApp message to anybody that wants to be involved in their particular surgery, giving the latest information, the statistics, what people should be doing. They've been doing that now for, how long is it, 18 months that this has been going on, and she passes it on to me and I read it. And I'm just very conscious that as a direct result of that, I know I have understood things that I would not otherwise have understood. Yeah. And I think that individual doctor surgeries could perhaps take that as a template. Yeah. It's Dr. Tanvir in Burnham, Junction 7 on the motorway. And it really is extremely informative, and it's very helpful to anybody that wants to spend 5 minutes looking at it and understanding what's going on.
Councillor Jeffrey, thank you very much for that. I think it's worth, I actually think that successful campaigns are going to be those which are most local and are actually led by the practices. And that's really where I'd like to focus efforts. I also want to clarify, because for the record, this is a public meeting, but actually we find our local media very supportive, and we appreciate their relationships. It's more of a national media voice from specific outlets, which we find the most destructive.
Yeah, and I would certainly say that my local surgery engages in Facebook, which is a main method of communication into the village, very useful there. However, they do themselves no favours at all by then having an online booking system for appointments, which gives you an appointment 2 weeks out, and don't tell you that in an emergency you can still make an urgent appointment. So there's a whole comms piece around everything here. Andrew, over to you. And then we'll wrap up this section. And if you want, Richard, if you want to remain to hear what Kate has got to say, feel free. If you don't and you've got to get off, thank you for your time.
Thank you, Mr. Chair. Thank you, Richard. Fabulous presentation. I think it really underlines we have a couple of things going on here. We have this sort of perfect storm of pandemic demand, aging population, rising long-term conditions, et cetera, falling workforce, which I think all the members of the board should constantly have in the back of their mind. You know, I think one of, the key aspects that probably hasn't been discussed in as greater detail is things as simple as, well, not as simple, but as housing and how that can affect the knock-on effect through here. So funnily enough, this board may not understand it does have some of the levers to actually help things out here. But a couple of quick points apart from coming back to the system and asking the system for help, and that does mean all system partners actually, because we will not get through this. We cannot leave the health service on its own. But I think I'd also like to make an appeal that we deal with this communications deficit that we have, and it is systemic in the NHS. So the NHS will quite happily commit funds to treatments and things like that. They will not do the same in communications. We have NHS campaigns, Public Health England campaigns after campaigns saying, go to your GP, go to your GP, go to your GP. And then we have the system saying, why is everyone coming to our GP? It's even the language. They never say, go to your nearest health centre or health provider within your, it's always the GP. So we've got to start changing language like that. While there is a systemic problem with GP recruitment, there is not a systemic problem with mark-on professionals. And we've almost got to understand, how did we go from having the public on the doorsteps clapping the NHS and all the carers, and rightly so, to some of the terrible abuse we're hearing about? That has happened in one calendar year, and that cannot be solved by medics. That needs to have comms professionals from NHS England all the way down, all the way through. I'd also make an appeal to utilise local partners. So there is a health watch in every single area throughout the country. We often are seen as the critic side of the critical friend, but we can also go in, talk to patients independently and talk about all of the good stuff. So I think transparency, better communication. The public cannot learn things by osmosis, and the system is very good at changing things and then just assuming the public know. There are so many ways of getting help, but it is confusing. We change things from minor injuries to urgent care centres, then back again. We never tell the public. So there has to be a proper systemic change in communications. I think that will help things, but ultimately we've got to address the bigger problems that you've addressed. But I'd just like to thank you and all your team.
Thank you, Andrew, for that. You've so articulately put. I almost didn't want to say anything because you captured it so well. The general practice is as either the dustbin of everything, or we are the superheroes for everything, depending on whether you're an optimist or a pessimist. But the comms has to be refined so people understand what we're there for and what we do and what we don't do and what's best done by someone else. I used the other thing, perhaps I'll leave it here, my last statement. We used to have home economics classes when we were younger. Well, I didn't, although I would have benefited from it. What we actually need is education for our children on the conditions, the self-limiting conditions which every human being suffers, and self-knowledge and knowledge and understanding about managing those ailments, because that's going to be a really important way of bottom slicing that work. So we don't see the fungal nail or the dandruff, but we do see those which we need to see. And that's no disrespect. There's always a case where actually your fungal nail dandruff, you do want to see it because it's something else. But education is really, really important, and I think that's got to go into schools and the education sector. Maybe this is something the ICS can look at. It's something I'd support.
Can I thank everyone who has contributed? Can I thank Richard particularly? So Richard, as I say, you're free to leave us if you wish, or to stay if you want to.
I'm going to stay for a bit longer and then jump out. And thank you for everyone for having me. I appreciate that.
That's fine. I'll come to Katie in a moment. I just want to say to members that time is moving on. We have a fairly chunky agenda, so can everyone be conscious of that as we move through the agenda? Katie.
Thank you, Chair, and thank you, Dr. Wood. Your presentation was very complimentary, and it provides a lot of context and background to what I'm just going to share. I'm very conscious, Chair, of what you actually said. I've got a presentation, but I'm going to abridge that presentation. But obviously, Gordon's got this, which will then be published across the website. So I'll just share my screen. So just to provide a bit more context about what Dr. Wood had actually stated. So what I'm going to share to you is just a couple of slides about what has actually happened in primary care. And the first slide here this is a sort of summary about what has been the impact of activity in primary care, and this is associated with primary care networks. This actual table here looks at what the activity workload was pre-pandemic, so from July 2019 up to date. And you can generally see here the massive increase that has actually happened to primary care as actually they've gone through the pandemic. You can see here there was some slight dips, and that was in relation to some of the isolations, but you can see here the burden that they are going through at the moment. And as Dr. Wood was talking about, those pressures are linked to several different things. It is a bit about the demand and extra secondary care work with regards to blood tests and starting medications, but also it's also to do with the access, because access points in primary care have ballooned. That started as part of the work pre-pandemic and has actually been rolled out during the pandemic as well. This is a bit of activity regarding the actual, by age group, about what's actually happened during those times. And what you can see here is the fact that down by the individual PCNs, what the increase is per month of the actual start from July 2019 to July 2021. And you can see here the variable rates by each PCN. To note here, one of the question was what was happening in West Berkshire. You can see here, for example, West Berkshire Rural PCN, they've had a significant increase in activity against some of the other areas such as Kennet, where actually they've just seen a slight increase. So it's all very much dependent on the individual populations that they're actually serving here. This is also a bit of background to what Dr. Wood was also talking about here about what has been the increase about face-to-face and telephone consultations. And we're seeing that generally that there has been an overall increase of both the telephone and also the face-to-face consultations. And that has had its benefits. And as Dr. Wood was saying, now we're going forward and we're expecting lots of the individual practices to actually do much more triaging of the individual consultations going forward. I'm going to slim down now to some of the activities that we've been doing. So as part of the overarching, I'm just going to go to the final slide here, but what we are doing as the commissioners of the of GP practices to really support them in those pressures is that, as Richard was saying, we're building up much greater intelligence of the activities that are going in primary care. And as Richard was saying, you heard that actually from a point of view of reporting, we only report on what's been the actual clinical consultations, but actively what we're trying to do now is also report on that unknown activity, that workload issues as well, because that are significant expectations that the GPs are having to deal with on a daily basis. 111 call handlers are now able to book into primary care. So on the point of view of access, this is the one thing to note. You can actually phone your GP, you can go online to your GP, but you can also go to 111. And we've seen lots and lots of ballooning of the actual points of access to GPs. And this sometimes I would say has caused some of that communication difficulties, because there's so many different access points. And we need to be smarter on how we're going to be able to access communications to GPs. Standardising telephone messages in general practice is a key thing. I'm sure that some of the Health and Wellbeing Board members here would say that there's lots of variability about what individual practices are doing. Some GP practices we've heard, they may have literally a couple of minutes in order to go through a telephone system in order to go through and actually book in. Others, it can be a lot longer. So we are supporting a much greater work of standardising those telephone messages. One key thing to note here has been what we've just recently supported is an extra £1 million for Berkshire West GPs, and that's to increase
the PC that runs the YouTube feed and effectively chucks the Zoom meeting out into YouTube has just dropped out, had a software update that no one could stop happening, so it decided to reboot. So we've got IT having a look at it at the moment. Bear with us. As I just said to members in the room, we shouldn't continue without being public and being streamed. So bear with us. We'll have I hope it's not 5 minutes, but we'll have a couple of minutes comfort break, and then we'll come back. It looks like it's rebooting now, so 2 minutes, and then we'll be back in the room, hopefully. Dawn, nod
Yes.
out. You can hear me. Thank you. Right, ladies and gentlemen, let me explain where we are. We believe that we are still streaming, so we think that's working. The problem is with the PC that runs the general YouTube software and runs the meeting. However, we are still all in the Zoom meeting. So what's going to happen, for those of you who have been in meetings in the chamber, you'll know that normally we use the desk mics and deliberately mute everything else so we don't get feedback. We're going to have to work it the other way around. All the desk mics aren't effectively working because they're not being picked up for the feed. So we are going to use our laptop mics, as I am doing at the moment, but we've got to make sure that we mute ourselves in between. Otherwise, we will definitely get some feedback. So, Katie, on that basis, unmute yourself when I've muted. Crack on.
Right. Can everybody hear me? Perfect. So I'll try and continue then and keep this really, really brief to a minute. So the CCG has commissioned additional 170 appointments per day across Berkshire West CCG. Now that is actually stipulated that with those additional appointments, we're expecting the GPs to do at least 50% of them as face-to-face. I would want to say that this ask was actually generated by the primary care networks themselves. So the primary care networks have come up with this idea and we're supporting them with that. That additional funding is actually only up until March 2022. I think it will start to sort of chip away at some of the issues that we've got, but actually it's going to be a sort of a temporary plaster as such. And what is really needed is what you've all been talking about beforehand, which was about making sure that the public are more fully aware about what's happening in primary care and how primary care has changed going forward as such. We're also supporting piloting of the actual emergency department at the Royal Berks, enable for them to book into GP appointments. Some people at the moment use the emergency department as an alternative. So we're hoping that actually that might actually help. But obviously with that, you would say that the emergency department has triaged those people already, and therefore they would just get an appointment. Obviously, we're establishing community pharmacy consultations as an alternative to GP practices, and that's something that Dr. Wood had already talked about. Lots of the primary care networks now also have their own pharmacists within there, and actually that is seen to be making a big difference. So generally, I think in summary, I'm not going to go any further. I think Dr. Wood has really explained some of the difficulties. As our overarching clinical commissioning group, one thing that we are trying to do is actually support those individual practices with some of those challenges that they have already. I will send out as part of this pack, we've recently just developed a very, very high level sheet, sort of almost like a poster that's gone out to all GP practices. And I would ask if this is something that the council would also promote through their websites, which just is an informative about this is what's happened. This is the differences that you will now see in general practice. Do expect the fact that you will be triaged. You will be assessed either via a telephone call, you could be assessed online, or you could be invited to come into your GP practice. Equally, the fact is you might not necessarily see a GP, you might be seeing one of the highly specialist nurses, a paramedic, or a pharmacist. It's a very simple sheet, but equally, I'm very much aware of the fact the other ideas that you're putting forward with the fact that the practices themselves need to be promoting the actual ways that they could be promoting access to their own local populations going forward. We are actively concerned about the pressures at the moment in primary care as a CCG, and we will continue to work with members of the local medical council like Dr. Wood, but also with our primary care networks in order to actually help them relieve the pressure going forward. That's just a quick summary of where we've got to. Sorry, it's been a very much abridged presentation, but I think Dr. Woods really summarised everything that was going forward. Happy to receive any questions.
Members, I will say, and I'll take a couple of questions, but you've heard me speak about the agenda and the fact that we've still got a lot to get through. That we will obviously take any comms pieces out. We have a number of comms channels to assist, and I'm sure we'll have that, take that offline and have that discussion. Councillor Doherty.
Just a point of clarity, thank you. I have. All right. Just a point of clarity, please. You say that the CCG had commissioned 170 additional appointments, but Dr. Woods said that there's a demand is outstripping supply and that there aren't enough GPs on the ground to do this. So how do you get those extra 170 appointments? Sorry, the two sort of seem to conflict. That you can commission them, yet the demand and supply issue. How does that go away when you commission them?
All this. Sorry. So yeah, you are right. So what we've commissioned is an additional 170 appointments across Berkshire West. Now that's extra money that's given out to the individual primary care networks and their constituent practices. They would be able to then get in extra locum GPs to actually help with those individual pressures as such. So what we've done, we've reassured, we did due diligence as part of this, because of the idea came from the individual primary care networks. Before we said this, we said, do you feel that you would be able to get extra locums to come in? So they went away themselves and just double checked, and they said, yes, they know they can get extra resources coming in. But the only thing with that is the fact that if you think about it, these are going to be GPs that sometimes the residents don't even know about. So it's going to be people that don't have that prehistoric knowledge as such, which obviously Dr. Wood had said, lots of the GPs know their populations already. So this is almost like it's a plaster fix. What's the long-term strategy is, as Dr. Wood was saying, we've got to be able to encourage more of the actual medical students to actually come in and see a career in general practice. unfortunately, at the moment, in some cases, general practice is not seen as one of those really aspirant careers. They really like to go into the acute trust. So trying to shift that balance to say, actually, there's some really good opportunities in primary care is something that we are actively working towards.
Andrew.
Two very quick points. One of the other excellent initiatives that's on there that hasn't been discussed is utilising our really fabulous pharmacists.
Andrew, can you bear with us because we haven't got sound in the chamber? Now we have.
Is that, can you hear me? Great. Yeah, two very quick points. There is an excellent part of the proposal to use high street pharmacists as additional relievers of pressure, because they are able, in some cases, because they're so well qualified to deal with lots of things, and also key, refer back to the GPs or to medical professionals if the need is there. And that's a resource that's just coming on stream and should really be used and used long term. But secondly, I think it's really important in this proposal, there is very little about comms. In all the time I've been dealing with the CCG, nearly 10 years, we have the smallest comms team across the ICS ever. It is a disgrace. It is causing some of these problems. It needs dealing with. We have the partners here to deal with it. You cannot keep blaming the public when they're not given the information, and it's not fair on primary care to deal with the consequences at reception desks or via the telephone. There has to be a commitment to massively improve comms, its speed, its transparency, its agility, because you're up against national newspaper outlets who are trying to sell newspapers with bad news.
Shall I respond?
What are we turning on?
Is anybody else? It just flashes.
Okay, I will. Do you want me to test a mic or what do you want?
I've got my mic off. Can you hear me now? Yeah. Sorry about everybody. Whenever we're having to go up to a actual screen to turn you off when the council chamber member speaks. So sorry about that. So Andrew, thank you very much for your comments. I recognise actually we have got the smallest comms teams here across the CCG. It has also been quite recently, we've had some people leave as well. So comms is a serious concern for us at the moment. I think this has been considered also by our Berkshire West Integrated Care Partnership. We do need to get on top of how we're managing comms. It's very, very depleted. So it's something I think I'll be raising with the ICP to take that forward.
Right, I'm going to speak and we're not getting feedback. So bear with us everyone, because every time you guys speak, who are zooming in, we have to mute the speakers in the chamber, because otherwise we get horrendous feedback. So we now move forward. Having to jump around screens, bear with me. Again, out of order, and I'm going to apologise for the lateness of this to Shushma, because we did want to bring this in order to allow her to leave. This is the hub report about suicide prevention, and page 155 of your pack. This is what we'll be voting on. So over to present the report.
Thank you, Councillor, and thank you, various members. I must declare right at the beginning, this strategy was actually written by my colleague, Karen Buckley, who's gone for maternity leave. But before she left on maternity, I chaired actually the only meeting of the suicide prevention group. So what I'm presenting here is something that's been written by somebody, but I have good knowledge having read it and having been through the approval process from the Suicide Prevention Board. So if I can just start, this is the suicide prevention strategy, which has been written for Berkshire, the background to it, and I think somebody was going to show the slides. If they're not able to, you might just be all right just listening to it, unless somebody can share the slides. I was told somebody would be able to share the slides. Is it possible?
Sorry, Sushma, I don't have the slides.
Otherwise, I'm quite happy because I've got those slides in front of me on another computer and I can, oh, right.
If you could present without.
I was told that somebody would be able to share it. I can actually try and share it. Let me try it. Yeah, brilliant. So, as I said, this strategy was written by Karen Buckley. If I could go on slide number 1, yeah, this strategy is based actually on the national strategy and national themes, but as they are applicable to the Berkshire West. So overall, we are trying to reduce the suicide in the high-risk groups in the community. We will tailor up our approaches to improve mental health. Can you hear me? Are you okay to hear me? Okay. We would like to reduce the means by which people can have access to commit suicide, information and support to those bereaved and affected by the family members who are affected by the suicide. We would also promote sensitive media reporting and support research, data collection and monitoring, and self-harm. Next slide, please. The method that was used was by refreshing the previous Berkshire suicide prevention strategy, which was applicable between 2017 and 2020. We used the expertise of the members of the long-standing Berkshire West Suicide Prevention Steering Group. There were people who have been committed to this cause for a long time. We also engaged with the professionals working in the statutory, private and third sector organizations. We established a Berkshire Suicide Prevention Strategy Working Group, and they worked to produce this strategy. And a smaller subgroup of the Suicide Prevention Steering Group was responsible for defining the content that was applicable to Berkshire West. Can we have the next slide, please, on the data summary? The data that we used for producing this was the ONS data, which was then polished and locally held by civil registration data. Berkshire Suicide Prevention 2018 audit, the NHS 0 to 25 years audit, the female suicide deep dive audit, and the impact of COVID-19. Next slide, please. The areas for focus for Berkshire strategy, and we chose that we should focus on children and young people, on women, on self-harm, on economic pressures, and those bereaved and affected by suicide of family member or friend. Next one, please. The overarching recommendations are that we should continue to monitor the impact of COVID-19 on the suicides across the life course through the various data that we have. We continue to monitor the wider trends emerging from the impact of COVID-19, and we undertake Berkshire suicide audit. We undertake regular reviews of information and resources, and we channel it for the people who are affected by suicide.
Sorry to interrupt you.
Yes.
Can you pause there? Now, we can no longer hear you because I have asked for the speakers in the room to be muted. I am conscious that we will very rapidly run out of time if we go through the entire slide pack you're presenting. I know that members have had the report, they've had the prevention strategy to read. I think what I would suggest is that we go to questions, and I again ask members to be conscious of time. This is nothing to do with those presenting, it's everything to do with technology in the room. But we do have a tight timetable and other meetings today. So apologies for interrupting you. But if I could ask members if they have questions, and as long as they're out of the room, I will be able to leave myself unmuted. So Councillor Burke.
Thank you, Chairman. We know that young people live a lot of their lives on social media, and we have had reports historically of young people being influenced to self-harm or even worse, to take their own lives through social media. Does the strategy need to include consideration of that?
It actually includes the action on young people, but not necessarily on the social media. You know what, thank you for interrupting it, because I was just thinking I should go only through the first 4 or 5 slides and give you the overarching recommendation. I realize it's a long presentation, and I'm glad that you have got the presentation. I would like to suggest that you give me all the questions. If I'm able to answer those, I will try and answer those. Otherwise, I'll take it back to the suicide prevention group, and they can, when they answer, I'll probably be able to send you some report on those questions, if that's okay. So I can't see anything specifically on social media in the whole of the strategy, but I understand that because there's been a national concern about social media, and that leading to isolation of young children and young adults, and leading to suicide. So that's an important question. Thank you for your question.
Councillor Doxey.
Thank you. 2 questions, one probably for you and probably one for Gary. So first of all, I noticed on page 31, was it 5? No, 9.1 of the report, that there's no public consultation. And I was actually quite surprised by that, because I would have thought that any form of public consultation will raise awareness, which itself is part of the suicide prevention strategy. I thought the suicide prevention strategy was really good, and therefore to not consult on it with the public seemed to me a lost opportunity to have this conversation with people that to help raise that awareness. So I was disappointed, if I'm honest, to see that there wasn't any public consultation on this particular policy. And then the second point was, I just noted with the steering group, and I hope I've got the right terminology right, there was 3 people represented from West Berkshire of about 60, I think I counted. And I was just going to ask Gary, do you feel that the West Berkshire voice came through? I noticed on the rates that West Berkshire actually had a particularly high rate, and yet there was only 3 voices from West Berkshire. So just a reassurance, Gary, that you felt that West Berkshire's voice was heard.
Yeah, again,
well, we've certainly been representing it from the West Berkshire Suicide Prevention Action Group. We've been attending as many of the meetings as possible. Probably, I would say, at least 80% of all the meetings that have been held over the last 4 years. And West Berkshire Council also has a public health officer that's been regularly attending. Rachel Johnson has been the suicide lead for West Berkshire Council attending. And also there's been other ad hoc members, including my vice chairman of the Suicide Prevention Action Group, Jerry, from Samaritan. So there has been another ad hoc attendances from time to time. So I think reasonable, yes. Yeah, thank you.
Councillor Abbs.
Thank you, Chair. Yeah, just a curiosity really. I'm looking around the ONS site myself at the statistics on suicide, and I see that the suicide rate, according to that data I'm looking at, is over twice the rate for men than women. So I was just curious as to why you specifically brought out, that we would focus on women when the rate for men is twice as high. They all need addressing, but I'm just curious as to why a gender focus. I see Councillor Stewart shaking her head, so clearly I'm missing some important information.
I think it was because the female suicide in Berkshire are higher.
Okay, so it's a West Berkshire specific.
Yeah.
Okay, that's fine.
Yeah.
Great, thank you very much.
Thank you.
And Katie.
Yeah, thanks, Shushma. Just a quick query. Obviously, this is a really comprehensive strategy as such, but is there an associated delivery plan for that? Because the strategy itself doesn't necessarily talk about, you've got lots and lots of recommendations, but it doesn't necessarily say what's actually happening with those recommendations, who's responsible for those, what is going to be the output for those as such. I just want to know whether or not the strategy group is also designing an individual delivery plan as well.
I'm going to bring Gary in there.
Well, thank you, Sushma. Obviously, I can't answer that question for the whole of Berkshire, but what I can do is say that what's been going on in West Berkshire, we've obviously been contributing to this along with the other unitary authorities. But I think it's important that you've raised that, because actually that there needs to be actions on the ground. And again, I can't speak for the other unitary authority areas, but what I can say is in West Berkshire, we adopted an attitude, a zero tolerance to suicide 4 years, in fact, 2017 in May, and we formed a group here. And I've got some things written down, because I think it's important that certainly West Berkshire members of this board and the public know that we are having a go at trying to prevent suicide as far as we can. So we established a steering group 4 years ago, comprising West Berkshire Public Health, Race and Welfare, Samaritans, CCG, Health Watch, GamCare, education leaders, local GP, a consultant psychiatrist, elected members, the Office of the Lieutenancy, the Coroner's Courts, Thames Valley Police, mental health mates, and others. Actually, I could go on. We've carried out training sessions here in this very chamber, in fact, for frontline workers and business owners, developed a play, developed talks at various venues, from comedy clubs to Rotary clubs. We've organised the erection of signs in partnership with West Berkshire Highways at strategic locations, car parks, motorway bridges. We've developed a first point of contact website now, which provides immediate and non-immediate support for people, which is now a first hit actually on Google in West Berkshire. And with part funding from this board, we've got a 1 day per week outreach worker now who is contacting dozens of local businesses, sports clubs to provide resources, information and training offers. And finally, with the help of the Surviving to Thriving Fund that's been contributed from West Berkshire Council and Greenham, we've managed to get a little bit of money for some training to upskill our outreach workers so she can become a frontline trainer, qualified frontline trainer in suicide prevention. So not only can we do the large scale 50+ training sessions as we've done in this chamber, but also for very small groups, 4 or 5 employees at a time. So I think it's important that those strategies are worked through and hopefully informing funding and budgets and so forth. But there is something that's going on in West Berkshire to meet some of those strategies.
Andrew.
Very quick last point. I'd like to commend all the work done that Gary's detailed. It really has been quite remarkable from where we were. But secondly, I've noticed a slight deficit in terms of how suicide is discussed within the health community, because it tends to always sit in the secondary care meetings and boards and very rarely seems to make its way into primary care. And yet in secondary care, 75% of suicides aren't known to secondary care. It seems to be the usual statistic. So as we're talking about transforming GPs, primary care networks, I think there's a real chance here to join up the work done by this board and also the transformation of primary care with new roles coming in specifically to deal with mental health in primary care to look at this really serious and important thing. So it's just an appeal really to make sure that we're joining the spaghetti up. Thanks.
I'd just like to add that the strategy was produced Berkshire-wide, and as I'm presenting it today to West Berkshire, I will be presenting it to all the local authorities for them to either adopt it as it is fully for implementation or make some adaptation locally before they adopt it.
Members, I don't see anyone else wish to speak, and thank you for that. We have a recommendation. The report has come from Rachel and Matt. As you've read the report, you've seen the draft strategy. It is for this board to approve the strategy. I am very happy to propose that from the chair. Does that find a seconder? Councillor Stewart, thank you. Virtual members and members in the room, an indicative vote, please, as to whether you wish us to take the strategy, either physical or Zoom hands on virtual if possible, because it's a lot easier for me to see them, and indeed easier for Gordon to see them. Put your Zoom hands down, please. Anyone against? Zoom hands up. Janet, you're voting against it. Put your Zoom hand down. Anyone abstaining? Andrew, thank you. And yeah, okay, so that members in the room having seen the indicative vote, those in favour, please show. And that is unanimous. Thank you, members. We move on. And I'm going to see if Dom is in the room. Dom, I do apologise for how long it's taken to get to your item. We're now going to move to, bear with me, item 11.
Thank you.
Our agenda, that's the rapid discharge programme. Dom, you've heard me hopefully say how under the cosh on time we are. Perhaps you could take account in your presentation. You nod. Over to you.
Thank you, Councillor Bridgman. I'll be brief. I've got a very few slides just to share some of the detail around this scheme. Let me do that now. I'm hoping everyone can see that's cover slide. Excellent. Thank you, Councillor Bridgman. I'm going to start by just describing very briefly what it is. Some colleagues on the call here today, the Zoom, will be very familiar with this, others perhaps less so. This is essentially a scheme across the whole of Berkshire West to ensure patients are able to be discharged from all hospital settings. That includes all of our community hospitals, as well as the Royal Berkshire Hospital, as soon as they're ready to go. What this does is apply some national guidance, the hospital discharge guidance that was first introduced with some additional funding in April 2020. And it's no coincidence that that was at the time of the first wave of our COVID pandemics. What's the difference? Why is this different from other such discharge arrangements? The principal difference is that it introduces a discharge to assess, or D2A approach. That means that rather than, very simply put, patients waiting in a hospital bed for an assessment to be carried out, and care needs to be assessed and the package to be readied, patients are discharged to a safe place, ideally their own home, if we can possibly make that happen, with initial care in place, and the full assessment is then performed in that setting rather than in an acute or community hospital bed. This scheme covers all of the 3 local authorities in Berkshire West, along with Berkshire Healthcare Foundation Trust and the Royal Berkshire Foundation Trust. And we focus on 4 pathways from 0 to 3. I won't read those out, but they're in almost escalating order of need. What are the benefits that we've seen from this? I think in summary terms, clear benefits to patients from improved outcomes. There's a lot of evidence that suggests that long hospital stays and delayed discharges can increase risks of infection, increase the risk of losing independence, and the risk of deconditioning, whether mentally or physically. There's an equality to this approach, so everyone has access to similar support at the time of leaving hospital, and it's a chance for long-term decisions to be made away from a hospital setting. And equally, it has removed the issue of funding delaying hospital discharge. I've just put up one chart to try and illustrate benefits to, in this case, the Royal Berkshire Hospital. The sort of fawn, orangey, browny coloured bars signify the number of patients in a given month who are on average waiting over 7 days for discharge on the Royal Berkshire Hospital site. And we've gone back until April 18 and up till July 21, just to show a full time series. The kind of steady black bar that runs horizontally through is what we're aiming for. And I hope what colleagues can see quite distinctly is a real shift from April 20 and May 20 and June 20 onwards in the number of patients who are so-called stranded within the Royal Berkshire Hospital site. What that belies is a huge amount of work across system partners in local authorities, from Berkshire Healthcare, as well as from teams within the Royal Berkshire Hospital, to expedite the care and onward discharge of patients who are ready to go, ready to leave. We're starting to see that number actually tick up at the moment. And on my final slide, that's why I make clear here that we are addressing and continue to work on a range of challenges in sustaining this model. That does include funding. We have benefited from national funding since the outset, and we will continue to do so through the rest of this winter. We've seen perhaps some unintended consequences because patients are discharged when they are medically ready to go from the Royal Berkshire site. We've seen that some of those patients have needed a higher level of care at discharge, which, as many counsellors will know, has increased the total cost of some of those packages, albeit that it's reimbursed nationally. And to my third point, placed some challenges on the care market, particularly the domiciliary care market. And I realise that's a particular issue in West Berkshire right now. And as a result, we've seen increasing numbers of patients awaiting discharge on a daily basis. This scheme is going to remain in place for the remainder of 21-22, and discussions about the scheme for 22, 23 and beyond are ongoing within the ICP. So that's our current position. I think we will continue to grapple with these issues, and one thing I'd be interested in is some thoughts from West Berkshire colleagues around how we together can grapple with the issues in the care market that we see right now, because that's ultimately going to challenge our patients and people from our community in getting to the right place for them in a really timely fashion. So, Chairman, I'll pause there. I'm very happy to take any questions.
Just waiting for the speakers in the room to be muted so we don't get feedback. Councillor Stewart.
Can everyone hear me? Yes, brilliant. I know you guys in here can, but not so clear that everyone else can.
So thank you, Dom. Very interesting. And as portfolio holder for adult social care, if I didn't actually make a comment, I would be horribly remiss if I didn't do that. And I was pleased. So I wrote down from your first slide, everyone has similar support at the time of leaving hospital. And then I was with a question mark, and then I was pleased, if that's the right word, to see that in your subsequent slides, you actually made reference to the fact that this is putting a huge sort of challenge onto the care market. And you mentioned domiciliary care in particular, which it absolutely is. Yeah. I know that we are working with our partners in the ICP, so we will be having those conversations. All I would say is, I am, in terms of your question, what can we do to help alleviate this? I would say, if you're not already working with the right people within West Berks Council and the Adult Social Services team, then get in touch with me and I will make sure that that absolutely happens. I know that we're trying to work with the market itself in terms of recruitment, to try and get more people into the care roles, the caring roles that we need. And I have to say that I'm very torn on this one, because I absolutely understand that we don't want people waiting in hospital beds, and that in most cases being at home is the best path to recovery. So it is a difficult one, but I guess I must end with saying what we don't want to do is effectively kick the can down the road and just move the problem on from hospital into the domiciliary care market. So
That was all I wanted to say, Chairman.
I'll invite Dom to respond, but if you just give us a moment, Dom, before you do, so we switch the speakers back on.
Thank you, Councillor, for those, I think, really insightful and constructive thoughts. We work really closely and very well, actually, with Andy Sharp and his team on this issue. And if I implied any criticism, that wasn't warranted. I've absolutely no doubt that the West Berkshire team are working really hard at this. But I'm really pleased that you sort of suggested that you'll continue to work at this, because I agree what we're seeking here is the best and safest place for every single patient and resident, and usually that's back in their own home with or without care. So the more that we can do to support teams like that in West Berkshire to increase the capacity in the care market, particularly the domiciliary care market, the better for all of our community, I think. So thank you.
Councillor Adams.
Thank you, Chairman. Well, my first statement really, obviously, totally in support of getting people back into an environment that's better for them as fast as possible. So I think that goes without saying. However, I'm a little curious as to who's in charge of setting the target and why they chose to drop it in April of 2020. I might have a guess at the answer, but do we actually know who sets the target? And
that's, sorry, Councillor. So that's, I should have been clearer. That's our own internal target here in the Royal Berkshire Hospital, and we use it as a kind of challenge to our teams to make sure that we're really bearing down on those patients who've got an extended length of stay inside the Royal Berkshire Hospital, recognising that this is a quality standard. So for us, we want to minimise the time that patients spend in hospital, because
we weren't under any pressure to change the target at that time.
No. We've done that deliberately. We adjusted when we saw a really sharp fall, partly as a result of the COVID pandemic and fewer medical admissions, partly because of the impact, the beneficial impact that the rapid community discharge work began to have really quite quickly.
Yeah, I would say, just go back, Dom, I think people going home as fast as possible is a healthy thing, not anything else. Thank you.
Thanks.
Thank you, Dom. And you are released. Members, that was. So I'm now going to try to run through two procedural pieces to get the agenda. I am conscious. Bear with me and we'll work our way through. So first item is, I should just look at you to shakes his head. There are no petitions, so that's item. Membership of the Health and Wellbeing Board. There is one change. Dom, welcome to a meeting, and farewell from the Health and Wellbeing Board, because you are being replaced by Raghav, and I would like to welcome Raghav into the Health and Wellbeing Board, and we look forward to contributions and joining us from representing Royal Berks on the board.
Thanks, Chair.
As you know, we assign positions on the board by a title, so there's no need to vote on that. We just note that change from the Royal Berks. It is important that we deal with item 8 on the agenda. That I think actually is the most important item on our agenda today. It's the joint health and wellbeing strategy. However, what I would say about the strategy is that it has been through the mill. It has been to this board on a number of occasions. It has been to the steering group on a number of occasions. It has gone through a public consultation. So I'm going to invite Sarah to say anything she wants to say, but I suspect there won't be a lot to say that we haven't already said about the strategy, and then we will move to a recommendation. Sarah.
Thank you, Chair. Yeah, I'll just give a really brief update. So as said, today I'm bringing the final version of the Berkshire West Health and Wellbeing Strategy to the board, hopefully for your endorsement before it goes to full council. As mentioned, the strategy has been in development since March 2020, and regular reports of our progress have been given to the board, and so I won't go over those again, but they are fully outlined in the report and the accompanying documents as well. The strategy consists of 5 health and wellbeing priorities underpinned by 8 principles, And as mentioned, we recently had a 6-week public consultation, which took place on the final strategy. That was in June to August of this year. The findings of that public consultation are described in the report, and these were used to further refine and finalise the strategy itself. While the strategy is shared between ourselves, Reading and Wokingham, each local health and wellbeing board is responsible for the implementation in their own area. And in order to outline how we'll do this, we have started to develop a local delivery plan for West Berkshire. That began in June with a workshop including members of the Health and Wellbeing Board and wider partners. And since then, we've been working with the different subgroups and other stakeholders to develop actions that are required. And this work is ongoing. However, today we're bringing the first draft of the delivery plan to the board for your review and comment. The delivery plan contains actions at a Berkshire West level, but also shared actions with Reading and Wokingham, where there are clear benefits to working across a larger geographical footprint. There have been early discussions with the two other health and wellbeing boards to understand where the actions align and how the governance of these will take place. And these discussions will continue over the coming months. The delivery plan for West Berkshire includes timescales for implementation and indicators and targets to ensure that we'll be able to measure our progress. And while it's intended to be in place for the first 3 years of the strategy, following which time there'll be a review and formal refresh. And I welcome feedback and comment on the draft delivery plans, in particular with regards to the level of detail that the board would wish to see included. Thank you.
Councillor Doherty.
Thank you, Sarah. And I have seen the strategy many times, so you'll be pleased to hear there's no concerns or issues with that. Just 2 points, one on your delivery plan, which I'll come to at the moment, but another one on the second priority. In 5.9 of the covering report, it says about the second priority of supporting individuals at high risk of bad health, that there is not one group that has oversight of all the work against this priority. And that just concerns me a little bit. It's one of the things I think if, I appreciate there's lots of different people doing the work, that if there's not one group that actually takes that responsibility and ownership, sometimes some of the delivery can get a little bit lost in prioritisation. So I was just going to make that particular comment. And then the other thing I was going to say on your delivery plan, it's good to see so much in there. Having sat on the Health and Wellbeing Board, I think since 2015, I think it would be really good if you could maybe break it down by years so that I can see the dates in there, but I don't really know what's in front of me for the coming year. And what we've done in the past is look at some quick wins, because I think there's an awful lot in there, which is good. And I appreciate why there's got to be an awful lot in there. But for clarity and for purpose, so that we can see how progress is being made against the strategy, it would help if it was one for the years in year order, but 2 to understand what the sort of quick wins, the ultimate priorities would be to keep us going forward. And I just sort of thought around the timing and structure as far as the delivery plan is concerned. I've got no issues with what's in it. It would just help from a board point of view to understand that.
And Sarah, before you come in, if I comment 2 things. Firstly, and I've said this many, many times before, that it's all very well having a strategy. It's the delivery plan that matters. It's delivering the strategy that matters. And the second thing, just to pick up one point on Councillor Doxey about timescales and timings and so forth, we have certainly had discussions in the steering group about the way in which this strategy is formatted and available. And we've certainly had discussions about using other software, Road Monk's been discussed, in order to make sure that who's doing it, when it's being done, how it's being done, what the cost is, and so on and so forth, are easily accessible by anyone who needs to, who is in that field and is looking at the delivery plan. But now I'll let Sarah just come back and then we'll go to a vote.
Yes, no, thank you. And thank you for those comments. I think they're really helpful. And I think it's, as Councillor Bridgman just said, the delivery plan probably won't look exactly how it does at the moment. This is for our purposes of developing it. But I agree that I think it would be helpful to be able to outline it by year. And as you say, kind of understand where our quick wins are and what is kind of actions that will be in train for a longer period of time. And I think just coming back to your first question or point, I think that forms part of a wider discussion on, the future of the sort of subgroups of the Health and Wellbeing Board and how it will be enacted, which is a discussion I understand that was planned for following the early development of the delivery plans. But I think it's a good point. Thank you.
So, members, virtual and physical, can I ask for Zoom hands to indicate whether you are in favour of adopting the recommendation to put the strategy as drafted to Council? I see a sea of virtual hands. Can I now ask for anyone who is opposed to that proposal to keep their hand up or put it up? I'm sure you're not voting against it, Matt. And anyone abstaining? Andrew, of course, thank you. Right, members in the room, having seen that virtual vote, can I please ask you to vote whether you vote in favour of adopting the strategy and putting it to Council? That is unanimous. I don't need to go to against or abstaining. Thank you, members. Thank you, Sarah. We move on. I'm now going to pick up, going to take us to item 14. I can let Councillor Abbs get off because I know he's got another meeting. Councillor Abbs, this, just to introduce this item, this is a motion on the use of redundant telephone boxes to accommodate public access defibrillators that was put to Council and then given to Health and Wellbeing to consider. It will be a Council, ultimately a Council decision. I don't think it's for Health and Wellbeing to actually decide, but you have a number of recommendations in the report, I think on page 204, and there is, as I say, a fairly comprehensive report upon the subject. So, Councillor Abbs, you'll know that you can speak to your motion, but you will no doubt have read the report in detail. So I invite you to speak to both, as it were, and be conscious of time if you wouldn't mind. Over to you.
Thank you very much, Chairman. I don't really want to speak too much, you'll be pleased to know, other than to say I am keen and will always remain keen to take every single possible opportunity to install more defibs. If anybody hasn't looked at the bigger picture, there is a fairly old set of data held within that, the link I've just sent to you on the chat, which relates to West Berkshire. It's easy enough to get a feed from the NHS to update those dots. But basically they save lives. So anything we can do as a council to encourage that, whether it be only one phone box a year or not, goes towards that end. And to be honest, Chairman, that's all I wanted to state, because it's a way of positioning ourselves to take every opportunity to do something more than anything else. What's the intent of the motion?
Councillor, I thank you for your brevity. Members, I see no question. I will simply comment that I am totally in favour. So provided that they are cited in a proper place and can be accessed and aren't sort of in the middle of the countryside. Certainly, we've just put one in on a member's bid into my parish, and I have been trained, was trained a little while ago in their use. So it's something close to my heart, as it is certainly close to Councillor Abbs. Members, you have recommendations at 3.1 and 3.2. I won't go through it. It's a fairly detailed recommendation. I won't go through it line by line. I will simply ask for an indicative vote as to whether you are prepared to accept those recommendations. Those in favour, raise Zoom hand, please. And yet again, I see a sea of Zoom hands. Lower and raise if you are opposed. And I'm going to make the wild assumption that Andrew Shaw is going to abstain. He nods. Thank you. So members in the room, having seen that, those in favour of recommendation at 3.1, 3.2, that is unanimous. Thank you, Adrian. Right.
Thank you for bringing it forward, Chairman. I do need to shoot now, but thanks very much.
Let me, I'm jumping around, obviously, And it is now item 10, I think. We move to working with refugees and migrants. I think speaking to this or available to deal with any questions are, and I welcome her into the chamber, Sue Howell, our Interim Chief Executive Officer, Carolyn Richardson from the Emergency Planning Service, and Janet Weeks from the Housing Service. So I welcome both of them, and I don't know who's splitting up what. Use this. So over to Carolyn.
It's over to me. Thank you, Chairman. I do have some slides, but I think I'll just see if I can quickly share them so I can keep this rattling through in relation to time. Can you see that at all? But not perfect, thank you. I'm just going to just briefly take you through as what we've actually been doing with the I say refugees, but mainly what I like to call them as evacuees rather than refugees as such, but just onto what we're actually dealing with here. We're actually dealing with a number of areas of migration, if you like. The main one being the Afghan resettlement and assistance policy set up by the Home Office. This has been actually been running since well, for a few months actually now, but obviously in the latter part of August really picked up significantly. Sorry, just go back. Picked up significantly, and as a result, as everybody saw in the news, the challenges that were being faced by the evacuees in Afghanistan and those then that were being brought into the country. When they actually arrived in the country, they then spent 2 weeks in the managed quarantine services in the hotels there, as a result of them being Afghanistan being a red country. And then after that, what's been happening as they're starting to move into the resettlement process, just because of the sheer volumes that we're actually dealing with at the moment, the Home Office have placed and procured hotels, which would be called either bridging or holding hotels. What I will say at this stage is I'm not going to be mentioning where the hotels are in West Berkshire or the numbers that we're actually dealing with, just they've for their sensitivities and their privacy as much as anything. So we have, I think it's been publicly known that we have got 2 of those holding hotels within West Berkshire, however, with a number of evacuees from Afghanistan there. We had less than 24 hours notice that this was coming to us. So it was a significant challenge for the organisation to actually step up and prepare, not least because we didn't know how many, where they were coming from, what conditions they were in, what their needs were. There was lots and lots of questions that we were actually dealing with at the time. But we stepped up and took hold of the situation, and more to follow in a minute. The resettlement process is something where Janet Weeks has been more involved in, and that's actually the process whereby we've agreed with this council that we will be resettling 3 families, households in the council, as have a number of councils right across the UK. Every council has been asked to support this. So we've agreed to support 3 families. On top of that, we've also got the asylum project that's been run again by the Home Office, which is just solely for the Home Office. We haven't been asked to do any wraparound support or anything like that at this moment, but things change quite a lot as we've gone through the process, so who knows. We're just checking some of the areas that we've, as the families arrived with us, we have had a coordinated group that is meeting daily and have been meeting daily since the families arrived. And I think some of the challenges that we were faced with and we were concerned about right at the beginning was actually what were the families actually arriving with, and actually they had nothing. Sort of a number of them, it was just plastic bags that they had. That was all that they contained. It was really quite heart-wrenching to actually see. They also don't have access to money. They didn't have money with them, so effectively they're starting from nothing. They've arrived, they've had the 10 days isolation. So they have a great deal more freedom than they've had before, which is great to see. A lot of children are involved. They're quite large families. We have a number of pregnant ladies who are in their final stages of pregnancy. We were concerned about their general health status, whether they had COVID vaccines, whether they had any flu, MMR, just the usual stuff, as you can see from the list there of where they were and what their conditions were, and how they were generally feeling. Importantly, mental health and well-being was one that we were particularly concerned about. And I would say that possibly now, some 4 weeks into this programme, I think we're starting to see maybe more of that, the mental health pressures starting to show. They've been stuck in a hotel for 10 days. They've now been with us, and they're looking forward to having that opportunity to give back to this country and get on with their lives. And it's quite a slow process at the moment. So I think the mental health and wellbeing element it's going to be a significant element going forward. There's obviously been language and cultural challenges. Positively, there are a lot of translators within the groups that we've got, as you would expect. So they've been helping us out, and we have all been learning each other's cultures. I think it's fair to say it's a two-way process and quite a joy to actually be with when you're actually with them. They are really, really keen to move on with their lives and absolutely desperate to learn, from whether it's the adults to the children. They're really keen to get on and learn English, and they're always different ways of saying hello and hi every time you turn up on site is great to see. We've also been over certainly the first few weeks been overwhelmed with offers of support, whether it was for donations, whether it was for actual physical support by way of teaching English, or whatever it may be. But we've been absolutely overwhelmed with it. In fact, we opened up our donations for bits of clothing, and literally, I think it was 5 days later, we were having to shut it down because there was just so much goods coming in. So we had to stop that coming through. So it's been really pleasing to see that. What we're doing now is, and actually what we've been doing in the last few weeks, is we have been working with the CCG, the GPs, the health visitors, the midwives, our own adult social services, the children's services, education. They're all coming together to effectively work out what we're the best way forward for the families they are residents of West Berkshire at this moment in time. So we have a local authority liaison officer on site every day, working with the hotel and the families, just working with others that are on site. We have been working through the community furniture project to manage our donations, which has been fantastic with them, to the point that we're now effective. I was going to call it a shop. I don't actually know which other word to do it is, but we now have an exchange location within one of the hotels that clothing is brought in, and the Afghans actually manage it themselves to actually coordinate what they're doing with the clothing, so that it's fairly distributed and is what they need. We've also got, obviously got the Green of Common Trust fundraising page as well, which we're looking to be towards working with the trust to provide school uniforms and school bags, pencil cases, things like that are practical, sensible things for the families to actually have here, and obviously when they get relocated as well. We're also we're working with Department of Work and Pensions. They're on site every day as well. We've had, as I say, lots of engagement with a lot of the professional partners, as you would expect, and as you can see from the slide there. I think there's been quite a bit of confusion right at the beginning. It's been a very fast-moving project, and whilst it was a Home Office project, there was a lack of clarity, I'd say, right at the beginning as to who was responsible for what. And recently there was an offer, if you like, proposed by, and a request effectively from the Home Office for the local authority to take on the wraparound responsibility. And we have just recently accepted that. I hasten to add that that's accepted and there's funding associated with it. So we're doing all that are being asked of us at the moment. What we're doing now is we are putting an education programme in place. As I said, there's a large number of families that are needing to be relocated to their final destination. That is likely to take some time, and it's unclear at the moment as to how long that will be. So the education services are working with a number of partners to come up with a more formalised programme, and working with schools to actually put them into schools or do some on-site education with the families and the children. We're looking at a programme for integration for all. One thing I have been very mindful of is road safety. It's quite different to Afghanistan to being in West Berkshire. So it's things like the road safety, how to get on a bus, how to get on a train, just basically their integration back into this country so that they're more prepared for their onward movement. Alleviating the boredom. It's a little bit of cabin fever when you've been in the rooms and in hotels. So we're just trying to engage with them about what they want to do and how we can actually facilitate it, or facilitating them to be able to do it for themselves is what we're trying to do, so that they are more equipped moving forward. Working with the CCG heavily in the mental health space, working with a number of voluntary sectors and other specialists, and importantly, it's actually working with the Home Office about the next steps. When are they moving on? Where do they move on? And what we need to do to make sure that they're ready for that next phase. We have, at the beginning of this incident, we declared it as a critical incident, and at the moment, that's where we're still at. There is likelihood that we may get some more families coming to us, as some of the families that have made their way across borders out of Afghanistan rather than coming through the flights that were coming out in August. So there may be that some more individual type families are still to come forward. So at the moment, we're still keeping it as a critical incident, but we'll keep that under review. And as we sort of start to manage the core services into their management of it, in this additional activity that we're doing, and I wouldn't say it's business as usual, but it's the way we're trying to move it is with some additional resources. We're moving to a more managed approach now. Janet may want to jump in a bit here, but effectively, as I said at the beginning, we've got 3 homes in West Berkshire that we've offered as part of the ARIP scheme. The matching has started from the Home Office point of view, and we're hopeful that we will be receiving some of our families very soon. Again, it's a multi-agency response and coordination. Janet's been chairing the meeting, the coordination meetings as we're moving forward with this process. I will keep going, and effectively what we're doing is we're using it on the basis of the Syrian programme that was very successful in 2015, so a similar approach is what we're doing. And I think that's all I've got to say. I have been learning some Arabic, so Tashakur. Actually, it's not Arabic, it's Pashto. Thank you.
Members, let me just comment. Both Katie Summers and leave for other meetings. We are therefore no longer quorate. However, given that there are no further votes needed and everything is for information, I'm going to continue the meeting, whether it is a formal meeting of the Health and Wellbeing Board at this point, or whether it has turned into some sort of discussion group. I don't care. We'll minute it as usual. So, members, questions. Councillor Stewart.
Thank you. Actually, it was my opportunity to say thank you to our officers in particular, who, as Carolyn has said, took this challenge on board and ran with it. And I have seen some evidence of we often say going above and beyond. Well, in this case, I think they really have done. I won't go into specific details, but this is officers that have don't have this obviously in their job description, but in terms of caring about people and looking after them and making sure that they do the very best for them, our officers absolutely did this. So I really wanted to get that message across. But also, and as Carolyn mentioned, the public were so keen to get involved and to offer their help and support, which was really lovely to see. And organisations, so voluntary organisations, also wanting to step in and do what they could. It really has been a heartwarming situation. But while I have Carolyn and Janet here in particular, thank you, and thank you to all of your colleagues for what you've done so far.
What I would say in response to that, from the day one to day now, it's been fantastic to see the changes.
You've heard a bit of that. Councillor.
Thank you, Chairman. Councillor Stewart beat me to it. I have had first-hand testimony from officers in the education team as regards the amount of effort all of our officers have been putting in to support these people in their time of need. And I'll just be brief and say thank you to Carolyn, thank you to all of our officers, Janet, who've been supporting the refugees.
Janet.
Thank you, Chair, and everyone. Just to sort of say, we have made some progress in terms of the offers. It's anticipated that the first family should be settling in by next week. So that's just a bit of progress since obviously pulling together the slides. So things are now moving, certainly in terms of the resettlement side and the 3 families.
I am just going to pause and what I'm going to ask Michelle whether you think we have enough time to do. I'm really looking to try to wrap this because we have other board meetings to go to. I was looking a bit twitchy. We have to get over to Shore House. So Michelle, I'd ask you whether you think we've got enough time to do your report.
So you cut out slightly, so I didn't hear what time you need.
Bear with us because we've got to speak it back on.
Sorry, I didn't hear what time you needed to finish by.
We were hoping to finish by 12.
Right, okay. I mean, I could probably do it in 5 minutes, but if you want more, then you might need to sort of ask questions. So I have some slides. I can abridge it.
Sorry, Michelle, just bear with us because we have to keep switching on and off the speakers in the room. Michelle, I don't think we will do it justice in 5 minutes. I think this is an important area, and I apologise to you for you having pitched up, ready to talk to us, and me then putting you off. But I do think that if we're going to give this a proper hearing, then we should put it back to the next meeting. And I'll liaise with Gordon about that. So apologies to you for having spent a considerable time listening to banter about things that are not your province. But let's push that one back and deal with it on another date. So members, the other items are pretty straightforward. A moment. We have Health and Wellbeing Conference. If you haven't heard already, that was penciled in for the 15th of October, but Mal has now departed from the engagement group, so we need to regroup, and we have put that back to the 21st of January. That will partly, part of the decision to put it is to enable us to look at the health and wellbeing strategy, and more to the point, the health and wellbeing strategy delivery plan as part and parcel of the conference. And we will certainly come back to you on all aspects of the conference in due course. There are no members' questions. The forward plan you have in your pack. If you have any commentary on the forward plan, could I ask you to email Gordon to pick those items up? And the dates for future meetings, I think, are in your pack. Yes, they are. So the next one is on the 9th of December. So can I say thank you to everyone for bearing with us? It's been a bit of an interesting time in the chamber, muting and unmuting, switching the speakers on and switching them off again. And we should go and kick a few people in IT probably, but there you go. Thank you all. If you'd stay online until we've had it confirmed that the live stream has ended, and then I'll call them, and I call the meeting to a close on that basis.